الرحمن الرحيم. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. في البداية حاب أشكر الحقيقة فريق تعزيز وتأهيل على إتاحة الفرصة لي لمشاركة الزملاء والزميلات في هذه المحاضرة، وأتمنى إن شاء الله أنه أكون قادر أوصل المعلومات المطلوبة والفكرة المطلوبة، وسعيد جدا أني أكون معكم الليلة. Our presentation today will be about cardiopulmonary patient screening prior to cardiac program and exercise prescription. The goal of our presentation for today will be we're going to highlight on the importance of cardiovascular patient screening and the tools and elements used for the screening. We're going to highlight also on risk stratification cardiovascular patient screening, and we're going to highlight also on other tools used, and we're going to end by evidence, talking about evidence or summary of the evidence in cardiac screening. If we said in the beginning, what is cardiac screening? Cardiac screening can be known as examination or test performed to find disease or problem before symptoms begin. The goal of these screenings is to detect disease and its earlier and most treatable stage. So before we get to problems, before we prescribe any exercise program for any patient, if we know the level of the patient, the endurance level, the functional capacity of that patient, by using the screening tools, we meet the goal. A screening program must meet a number of criteria, including reducing the number of deaths from the given disease. Who should consider heart screening? To whom we should do screening? We can do that for any patient diagnosed with coronary artery disease, which is the most common and a major cause of myocardial infarction or heart attack, or any individual with high risk factor problem. Why it is important? As we mentioned before, because screening identifies those at risk of future cardiovascular problem and other major body organs. In addition to that, it identifies those with modifiable risk factor, which are reversible and reduce the risk of developing of cardiovascular disease. As we know, some symptoms of cardiovascular disease are silent, and advanced obstructive coronary heart disease can exist with minimal or no symptoms that progress suddenly and rapidly and may cause sudden cardiac death. The first clinical manifestation of coronary heart disease, acute myocardial, risk factor of silent symptoms of cardiovascular disease. It is often associated with significant morbidity and mortality. Now, what does the screening test include? I'm going to share you this short video. I hope you are listening to it.
In this short video, I'd like to describe for you cardiac or heart screening. Heart disease is a leading cause of death in the United States and a major cause of disability. Coronary artery disease, often referred to as CAD, is the most common form of heart disease and a major cause of heart attacks. Coronary artery disease occurs when a buildup of fat, cholesterol, or other substances called plaque collects and forms along the walls of the heart's arteries. It's a condition commonly referred to as atherosclerosis. Cardiac screening exams are performed to find heart disease before symptoms begin. If your doctor prescribes cardiac screening, you may be evaluated also to measure cholesterol, blood glucose, C-reactive protein, and blood pressure. Depending on the initial test results and your risk factors for coronary artery disease, you may also undergo an imaging test. Some of the more common tests are echocardiography, which uses ultrasound to create moving pictures of the heart, cardiac CT for calcium scoring, or coronary artery calcium scoring, which measures the amount of calcium in the coronary arteries and may be an important indicator of the presence of plaque. Coronary CT angiography, or CTA, which uses computed tomography or CT scanning to determine the location and extent of plaque buildup and look for any areas of narrowing. Myocardial perfusion imaging, or MPI, also called the nuclear stress test, uses a small amount of radioactive material and a special camera to determine the effect of physical stress on the flow of blood through the coronary arteries to the heart muscle. And finally, coronary catheter angiography, which takes images of the blood flow through the coronary arteries and allows the doctor to see any blockage or narrowing of the coronary arteries. It's important that you talk to your doctor about which test is right for you. You can find more details, including the risks and benefits.
So in the past short video, we listened to the most common test, and there's more coming that's usually done for cardiovascular patient, and it depends on their condition and their need of that particular test. Also, in addition to those tests, carotid artery ultrasound screening to identify the presence of blockage in the carotid artery is also done. Peripheral artery disease ultrasound also used to detect any peripheral artery complication, and it's most common on people with diabetes and history of smoking. Abdominal aortic aneurysm, I hope you are familiar with that, and it's a condition in which the aorta, the largest artery in the body, stretches the balloon. If you look in the picture, it will be bulb out, and it might rupture anytime. So those type of patient has to have a really normal blood pressure and low blood pressure to protect the internal aneurysm from rupture. And when this occurs, it weakens the wall of the artery and can rupture, as I said, causing bleeding and into the abdomen. So this is one of the ultrasound tests also done for the coronary, for the arteries, abdominal arteries. Atrial fibrillation screening, also known as arrhythmia. Atria do not beat at a regular base. So this is one of the screening that the physician do to make sure that there's no atrial fibrillation. Complete lipid panel screening, as we know, the high cholesterol, and we are familiar with the high density lipid cholesterol, the HDL and LDL, and their normal level. And actually, most of these tests and the lab result will be done by the medical team, and it will be ready for you in the patient file. And for the normal range, of those screening, we're going to talk about this in the coming slides. Also, one of the screening tests is the C-reactive protein. Is a simple finger stick blood test to detect the level of reactive protein in the blood, and it is a marker for inflammation in the body, because any injured artery can cause the body to release this C-reactive protein. So if we did this test and we find like the level of the C-reactive protein is high, that means and it has a really big correlation to inflammatory of the blood vessels and the artery. That's one of the indicators also being used in screening. There's if you are familiar with the ESR, it's also a kind of a test, but that test usually done for joint inflammation or for infection. And if we want to compare between the two, if the ESR test done, we know that they are talking about bone and joint and the infection or inflammation in the bone and joint. But if they are talking about the CRP, the C-reactive protein, they are talking about infection in the urinary tract, or they are talking about blood vessels or venous thromboembolic disease. Talking about the normal level of this C-reactive protein, there is a low, average, and high level, and usually now in most of the systems in the hospital, they give you the normal range of the every lab test, so you don't need to memorize those number. Just go on the system, right click, it will show you the normal, the average, the right. But for just for information, if it is less than 1 milligram per liter, so it's low risk. 1 to 3, it is average risk, and if it is more than 3, it will consider as a high risk. That means there's a high risk of inflammatory disease or high risk in the blood vessels. Do high level of C-reactive comes with symptoms? The answer is yes. One of the symptoms is unexplained exhaustion, pain and muscle stiffness, soreness and weakness of the joint, low-grade fever, headache and nausea, loss of appetite, and difficulty in sleeping or insomnia. Also, one of the important screening is the level of blood sugar in the blood, and we know that diabetes mellitus refer to a group of disease in which body either does not produce enough insulin, or there is no insulin at all. And here we're going to differentiate between type A and type 2, but we have to be like familiar with the normal blood level or blood sugar level for diabetic patient. If we're dealing with diabetic patient, before we start the exercise, we have to know if Are we dealing with a diabetic patient or non-diabetic patient? If diabetic patient, did he take his meal? Did he take his insulin? Did he take his tablet before doing the exercise prescription or starting in the cardiac rehabilitation program? And as we know that blood sugar is the primary energy source for the brain and also critical to cell and to tissue in the body. Also, one of the screening, the blood pressure, I think everybody is familiar with the normal level of the blood pressure. And I found this, really simple. If we could have like a blood pressure machine in outpatient clinic, just before having a patient starting his exercise or riding his bike or starting the exercise program, if we could take his blood pressure to know his level of blood pressure. Also, if we have an idea of his history of hypertension, because every patient has an individual reading for him. Some patient, they might have 140/90 at their normal level of hypertension or of blood pressure. Other patient, they might, if they have like 140/90, they will be categorized as hypertension. So if we're dealing with hypertensive patient, we should know the normal level or the daily living, daily reading of his blood pressure. Then from there, we can start by measuring his blood pressure before exercise and during exercise and after the exercise, to make sure that this patient will not go to hypotension or hypertension with exercise. However, exercise is always pushing the hypertensive patient toward normal reading. So whatever was the patient having from reading, if the blood pressure was high, always exercise driving or pushing this hypertensive toward the normal reading. Okay, so as I mentioned before, most of this reading for inpatient setting will be ready either in the monitor for blood pressure and other thing. It will be in the system if you read the patient file. All this information will be in the patient file, and really it's important to have all this information with you before dealing with the cardiac patient. And also it's important to know patient medical history. Check on the attachment of the patient. Is the patient having a recent surgery? Is the patient having any equipment attached that might bring out bleeding? So we have to check out the surrounding of the patient. Check the monitor to know the patient stability. We have to check the heart rate, the blood pressure, oxygen saturation. Is the patient stable or having arrhythmia? So before deciding if we can deal with the patient, we have to see also the level of consciousness and ability to communicate. All that will help us to decide if the patient is fit for our assessment or treatment or not, before even starting to touch the patient or try to put any exercise prescription for this patient. In second hand, for the outpatient, usually there is several tests could be done for cardiac patient prior to exercise prescription or starting the exercise program. And before talking to about that, I'm gonna ask here, what do you think physician needs to know about your field? What do physician needs to know about the physical therapy field or the cardiopulmonary hub specialists can do for my patient, especially for those post-cardiac event, for those post open heart surgery. And here we're going to talk about all this. Physicians should know that cardiac rehabilitation is an essential component of care for all cardiac patients, regardless of their cardiac event. And it is a medically supervised program for patients with established cardiovascular disease. So we are dealing with most of the cardiovascular cases. And the goal of the comprehensive program is to help patients with cardiovascular disease to recover quickly after cardiac events, to reduce the risk of future cardiac illness. Now, which coronary artery disease or cardiovascular patient should be referred for cardiac rehabilitation? Actually, the evidence-based reported that depending on the type of initial cardiac event and the individual circumstances, so the cardiac rehabilitation process may differ or may differ in its goal from patient to patient. On certain category of patient may benefit particularly from specific component of cardiac rehabilitation. So not every patient we can apply the cardiac rehabilitation elements or program for every patient. Every single patient will be having an individual situation and has to be having a tailored exercise program for this particular patient. Okay, as I mentioned before, which patient group will be benefit from cardiac rehabilitation? I think the majority of patients, even those with acute cardiac events, patient post-surgery, patient with heart transplantation, with ventricular assisted device, most of the patient can benefit from the cardiac rehabilitation if we know how to screen them properly, if we know how to categorize those patients properly, and how to do the tailored exercise prescription for them. And in a short few minutes, we will talk about this. Now, what should you know prior to cardiac rehabilitation? And this is really important. As we said, the medical and surgical history of the patient. You have to review the recent cardiovascular tests, which include lab result. We have to check on the hemoglobin level, red blood cells count and white blood cell count, platelet count, as I said, if there is inflammation, the C-creative protein, the ESR, the also low density and high density level protein. All these tests, we have to be familiar with it to at least to know if they are in high level, normal level, or in low level. In addition to that, 12-lead ECG result we shouldn't be like, you know, familiar with everything and how to interpret all the 12 ECG, but at least we can know the result of this. Is the patient sinus or having arrhythmia? And the most important thing is that we're talking about sinus. Is the patient sinus sticky or sinus breathy? If the patient is sinus, that means okay, but if there is any arrhythmia, then we have to be careful with that. Should we start or not? Talking about the ST segment or ST elevation or depression, we will talk about this in more details in a second. Arrhythmia, etc. So we have to know at least the result of the 12-lead ECG. We have to know the result of the coronary angiogram, stress test, echocardiogram, at least to be familiar with the patient situation period to start the exercise. And in addition to that, if we know the disease of the patient, we have to know at least the prognosis and the comorbidity of that disease period to that. Cardiovascular risk factor, is the patient obese, male, female? What is the you know, the patient functional capacity? All these parameters, we have to be familiar with it. And in addition to that, talking about the functional limitation that the patient has, and we can detect this through the objective test, which we're going to talk about it in a second. In addition to that, the current medication, because some medication has adverse effect on the patient. If we're dealing with hypertensive patient, for example, and this patient is taking an antihypertensive drugs, if this patient take this medication, when did he take this medication? Did he take it 10 minutes before coming to the exercise program? He take it 2 hours before? Because sometimes the exercise may react with those medication, and suddenly we find that before this patient starting the exercise, he used to take his antihypertensive drugs and he's fine. But while he started the cardiac rehabilitation program, the exercise started to normalize his you know, his hypertensive level or high blood pressure level. That means we have to be careful with contacting the medical team when we measure his blood pressure before the exercise and after exercise, and we have to have this highly medical team communication between the physical therapist and the medical team. Now, more important things here, you have to know what categories can you classify your patient. And we're going to talk how you can define that, what is the endurance and functional capacity level, and what are the existing tools of measuring those two parameters. Okay, classification of patient depending on their cardiovascular risk. Thomas et al. 2010 came out with the classification of patient to 4 categories. Class A is a healthy individual with no increased cardiovascular risk with exercise. Class B, clinically stable individual at low risk of cardiovascular complication with vigorous exercise. And Class C, patient at moderate or high risk of cardiac complication during exercise, including patient with history of, for example, myocardial infarction, left ventricular dysfunction, or cardiac arrest. Class 3 of New York Heart Association classification. If you are not familiar with that, I will talk about it soon. Function exercise capacity of less than 6 metabolic equivalent tasks. We're going to talk about this also. Patient with significant ischemia at exercise testing. And Class D, patient with unstable cardiovascular disease or heart failure for whom exercise is contraindicated. So if we look, we're talking about normal in Class A. In Class B, we're talking about nearly normal, but those cardiovascular patients with low risk, and if they do high risk exercise, then they will, vigorous exercise, then they will be in high risk. Class C, this is the majority of our patient, and Class D, those the contraindicated patient. More evidence now in classification, something called cardiac risk stratification. So cardiac risk stratification, now here we're talking about evidence-based classification of patient. And cardiac risk stratification means careful evaluation of clinical and functional status of patient, starting with clinical history, physical, laboratory, and other tests, in order to classify the subject individual in 3 categories: low, moderate, and high. If you look at this busy slide, here I'm talking about the different protocol or the existing protocols. We have different protocols, but the most important protocols in categorizing patient in 3 classification is the American College of Sport Medicine, also the American Association of Cardiovascular and Pulmonary Rehabilitation. These 2 are the most common, association that used for patient classification. Others, like the American Heart Association and the Brazilian Association and the rest, are used, but those 2, the American College of Sport Medicine and the American Association of Cardiovascular and Pulmonary Rehabilitation, 2007. And the good thing, the majority of these categories of patient uses the same classification: low, moderate, and high risk. So most of them are using the same, except maybe the American Heart Association, they're using like Class A, B, C, and D as the previous classification. Why it is important? As we mentioned before, to help patients achieve the best health and quality of life possible by preventing chronic disease and preventing higher association or higher associated cost. What are the categories used by the American College of Sport Medicine? As we said, low, moderate, and high, and they have actually a calculation for this. If their calculation became more than 15%, that means the patient has high risk of having cardiovascular disease or high risk of having mortality or morbidity. If it is between 10 and 15, medium risk. If it is less than 10%, the patient will have a low risk. How do they calculate this? They have a questionnaire. Actually, the American College of Sport Medicine have a risk screening questionnaire. They ask the patient several questionnaires, and they here categorize the patient according to their, risk stratification scoring. Then they put the full score, and depending on that score, they will talk about. They will categorize the patient. They will categorize the patient as high, medium, or low. Okay. The other school is the American Association of Cardiovascular Pulmonary Rehabilitation risk stratification. As I mentioned, they have also a low risk. Patient would be at low risk if there is absence of dysrhythmia during exercise testing, absence of angina or other significant symptoms. The ejection fraction is more than 50% at risk. And they categorize patient in moderate risk if the patient having at risk of having angina or any significant symptoms like short of breath or dizziness, during exercise, mild to moderate level of silent ischemia during exercise testing. That means if the patient having ST segment depression of less than 2 millimeter from baseline, the functional capacity of that patient is less than 5 meds, and the ejection fraction is 40% to 59% at risk. The last category is the high risk if the patient having arrhythmia during exercise testing, angina, other significant symptoms of at low level of exertion, more than or equal to 5 meds, high level of silent ischemia, that means ST segment depression, more than 2 millimeter from the baseline during the exercise, and the ejection fraction even is less than 40% at rest, and in addition to history of cardiac arrest or sudden death. Now, as we have been talking about the metabolic equivalent task in most of the 3 categories. So I just need to highlight on the metabolic equivalent task as one of the tools used for patient stratification or knowing the level, the functional level of the patient. So a METS is defined as the resting metabolic rate, that is amount of oxygen consumption at rest, which is equal to 3.5 milliliter per oxygen per kilogram per minute. So time, weight, and oxygen consumption is included in this metabolic equivalent task. And if we look at the right side here, the metabolic equivalent task actually they divide that according to the activity of the patient, and we're going to see that in the coming table. So it indicated in many of the protocols, as we see before, of the main reference for determining the risk level of each individual, and by using the METS, we can compare the exertion required for different activity, and we can know the level of activity of that particular patient period to exercise. This table here can show us, like if we say this patient has METS 3. So METS 3 means patient can do standing from the floor. That will be MITS 2. MITS 1, when the patient lying down, just like reading and avoiding like any body movement. So they categorize metabolic equivalent task to up to 9, and each level is associated with the functional level. So this MITS has the MITS task is actually one of the most parameters used in research if we want to combine the patient activity with the functional capacity. When we say the functional capacity of this patient, using the 6-minute walk test, which we're going to talk about it in a second, or incremental shuttle walk test. So we can translate the incremental shuttle walk test activity or the 6-minute walk test activity to the MITS, which can translate the patient functional activity and describe the activity of the patient and translate it to numbers. So as I mentioned, if we're talking about MITS and exercise intensity, any intensity, light intensity activity, anything under 3 minutes. We're talking about sitting, doing a computer work, reading. If we're talking about anything more 3 to 6 minutes, we're talking about moderate intensity, aerobic physical activity, walking and treadmill. If we're talking about more vigorous intensity, aerobic physical activity, we're talking about doing running, jogging, weightlifting. So we're doing high intensity level of exercise. So here, which I was talking about, joining or talking about exercise intensity and MITS. Also, one of the screening tools is exercise stress testing. It is a valid diagnostic test for cardiovascular disease or coronary artery disease with symptoms. And also, the risk is determined by the American College of Cardiology Foundation and American Heart Association. They really support. We're gonna go through this short video to talk about indication of exercise and stress testing.
Hello, my name is Greg Poudre, Manager of Cardiopulmonary Diagnostics and Cardiac and Pulmonary Rehab here at Legion South. And today we're going to be talking about cardiac stress testing. The indication for cardiac stress testing is to look at the physiologic effects of your heart. We want to look at the rate at which your heart is beating. We want to look at the response of the heart rate. We also want to look at the response that you have with blood pressures during the test. So we're physically looking at the heart physiologic action, or the action of the heart, how it's working under stress. Now, the indications for the cardiac stress test are many. It can be for a cardiac evaluation for surgery. It can be for a patient who comes into our emergency department with chest pain and it's unspecified. So we have a cardiac stress test to identify whether or not there's been any type of damage to the heart. All patients who come in for cardiac stress testing, independent of the type of test that they have to have a standard 12-lead EKG electrocardiogram prep attached to them so that we can effectively monitor the rhythm of the heart. We have a number of cardiac stress tests that we perform, and a lot of it depends upon what we're looking for and the level of the patient's ability to perform a test. With our cardiac stress testing, obviously we try to get patients to perform exercise. Exercise is the best way to stimulate the heart and to get an accurate view of how the heart is responding. Many situations the patient is not physically able to exercise, so we have to resort to using a chemical stress test, either an adenosine or a dobutamine, to simulate that activity of the heart.
Sorry.
To evaluate the function, blood pressure, the heart rate, and the ECG changes, if any, of the cardiac stress test. We do probably anywhere from 10 to 15 cardiac stress tests a day, a variety. Today, I think we're doing some, half our tests are chemical. We have many that are walking tests. We have 3 or 4 of the echo stress tests. So we're very versed in it. It's a very safe procedure. It's something that's very diagnostic, and it's helpful for the cardiologist and your family physician to determine what your heart is doing.
Okay, so when the patient did like the stress test or the angiogram or all this, they have to have like a summary result. So as I mentioned before, I'm gonna just highlight slightly on the evidence summary, especially about the ST elevation. So ST segment elevation of more than 1 millimeter during stress test identifies areas of ischemia and proximal coronary vascular. So when we're talking about the ST segment, we know that we have like the P wave, QR, S. The S should be here in this level, or to the level of the baseline. But if we look here, we can find like a kind of elevated T. There is also some reading which we find a depressed T. The T is going down. So they are measuring the how high this T goes up from the baseline, how far did the ST goes down from the baseline, and from that they will do the diagnosis. So if it is elevated more than 1 millimeter during the stress test, that's an indication of ischemia in proximal coronaries. If the ST segment depressed more than 2 millimeter and does not localize, but when combined with clinical symptoms, ischemia suggested. Like if they find out like there's ST segment depression, and in addition to that, there is like signs of fatigue or short of breath, then that's also another indication. Also, if while they're doing the test, some patient they will spend like 10 minutes before they show any change in the ST segment. And some patient they find like a sooner ST segment depression, and this is also an indication of more severe coronary artery disease. So the sooner the ST elevation or the sooner the ST depression, the more severe of coronary artery disease. And as exercise increase, we know that cardiac output, systolic blood pressure should increase, and inability to increase in systolic blood pressure, that means or that suggests a left ventricular systolic dysfunction, or also an indication of coronary artery disease. This is just a relative indication for the ST segment, the one I was trying to explain. If we see here, we're talking about a normal patient, and here there's just a little slight depression, which is also nothing. Here we're talking about more than 1 millimeter depression. Here we're talking about more than they're talking about horizontal ST segment depression. There is no direct depression of the ST segment, and the P, they call it P R interval. And if you see here, we have a certain time for the the ST to appear. If there is a prolonged arm, then the ST segment appear. That's also a diagnosis for a cardiac problem. But the most important thing here, which we have to be familiar with, if there is a down sloping of more than 2 millimeter, really that's relative indication for termination, for stopping the stress test, even if there is no symptoms appear with the patient, like short of breath or fatigue. Some patients, they cannot, run in the treadmill. They cannot ride a bike, because as we know that when they do the stress test, the patient has to, as we saw in the video, has to run in the treadmill. If for elderly patient who like have other problems, they did surgery in their knees, they are, unable to stand and walk, there is a pharmacological stress test. So they are using drugs that affect on the heart rate, and it affects as the patient is running on the treadmill or running on the bike. And they are, as soon as they are injecting the drug, they will be monitoring the screen. They will be monitoring the ST segment elevation and depression. So it is a diagnostic procedure which cardiovascular stress induced by pharmacological agent. It has been established after the exercise testing in patients with decreased functional capacity, as I mentioned, or those who cannot, walk. And this take about 3 to 4 hours, because they cannot inject, the drug quickly. They have to inject the drug slowly, and then monitor any changing in the 12-lead ECG. One of the other tests also is the New York Heart Association functional classification, used a lot by the physician. So if you are reading the patient's file, especially if they are talking about the functional level of the patient, you find them classifying patient to 1, 2, 3 of New York Heart Association functional classification. This classification classify patient with heart failure according to the severity of their symptoms, and this table here show us the category and the level of the clinical importance of this classification. So we have 4 levels: class 1, 2, 3, and 4. And if the patient has no limitation of physical activity, that means classification of New York heart association of 1, 2, slight limitation of physical activity, 3, marked limitation of physical activity, comfortable at rest, but less than ordinary physical, and result in short of breath, fatigue, and sometimes palpitation. Class 4, unable to carry any type of exercise, or if patient try to do any type of exercise, will be feeling discomfort, symptoms. Also can present even at risk. So the patient might have short of breathing, fatigue, sweating while at risk. So these 4 categories are the New York classification, and we find it a lot in cardiac patient. So if we see class 2 or class 3, we know what level of functional impairment is the patient. Now, these tools, 6-minute walk test and the shuttle walk test, are really functional tests that help us, even in outpatient setting, to know the functional capacity of the patient. It is commonly utilized, by the therapist to know the level of functioning of the patient. We can use it to know the endurance level of the patient. It is really simple, objective, reliable, valid, and very sensitive tools that provide reproducible measurement of functional capacity. What we want is space that we know this space how long. If this space is, for example, 30 meters, we have to have, like, from the name, 6-minute walk test. So the test will take 6 minutes. So we will have the start and the end. Then we ask the patient to walk between this 2 start and end, and we measure how many times did the patient walk in this, multiply this by the the space or the meters, how many meters. We said 30 meters. If the patient walked 10 times in this 30 meters, that means 300 meters. And actually, for cardiac patient, I'm not familiar if there is, like, for the Saudi population, if we have like a normalization number for or average number for cardiac patient. And I think this also is one of the major point of thinking of having a research of doing the cut-off point for the 6-minute walk patient for Saudi population. So as I mentioned, what we want to know is the pre the test, the vital signs of the patients, and the distance that the patient, this, if we're doing research, if we're doing exercise program for those patients, we just need to have this information with us. Then if the patient is is doing like a 6 to 8 week exercise program, after finishing the program, we can redo the same test and compare between the first reading and the second reading to see if the patient functional capacity or the patient endurance level improve or still the same, so we can modify the exercise program. What is the disadvantage of this 6-minute walk test? It allows the individual to set the speed of walking. To me, this could be an advantage and disadvantage, because sometimes some patients you cannot force them to run or to walk. So the advantage could be of this 6-minute walk test is even the patient, if using a cane or walker or walking slowly, you can perform the test. The other disadvantage reported is it is affect gender, height, and weight. I think this could be a disadvantage when we are using this in a research base. But if you're using this test just to know the functional capacity or the endurance level of to control all these parameters. One also of the really test, which they say is even more evident than the 6-minute walk test, is the incremental shuttle walk test as a functional capacity test. It is more related to cardiopulmonary and pulmonary patient. The original purpose of this incremental shuttle walk test to develop a standardized, extremely based test to assess the functional capacity in patients with chronic airway obstruction. So when this test started or began, they did it on or for chronic airway obstructive patient. Then many studies has been done and validated, and they found it more correlated to cardiopulmonary patient. So the test is valid and reliable for functional capacity that relates strongly to VO2 max, which is one of the strongest, tool measure for the functional capacity, which really need a lab. But we're talking about a simple test that you can run in the physical therapy department or in the clinic to know the functional capacity of your patient, and then you can tailor the exercise prescription or exercise program for your patient. So this incremental shuttle walk test, if you are familiar with that, you can have a break of a minute. If you're not familiar, in the shuttle walk test, he's trying to explain to the patient to run from place to place, and as you've seen, we have to have 2 cones in 2 ends, and the patient has to walk between these 2 cones, and it has the patient has to be at the end with the bell ring, and the bell will increase the time of ringing every like every 24 seconds. So every time the patient runs from the cone to cone or walk, so in the beginning the patient could walk easily until catch the cone and stay there. Then the bell will ring, then he will walk to the other side. Then he will walk and run to the other side. Hold on, let me show you in the video. Sorry. Okay, so as you see here, we have these 2 cones, So he's trying to explain to the patient, because we have to explain to the patient that he has to start from here, and we know that the distance between here and here is 10 meters, and the patient will be asked to walk from here to here, then stop until the bell ring, then he has to walk again to here and stop until the bell ring, and the time of between the first and second bell will be shortening. I'm sorry, I said it should increase. No, it will decrease slowly. So the patient has to catch the second cone before the bell ring. If the patient fails from catching the second cone before the bell ring, then the test will be terminated. And I will leave you to see. You see that in the beginning he's walking slowly to catch the cone. So any patient with any cardiac event will be able to do the test. But and slowly you will see like the patient has to run to get the bell. So as you see, he didn't catch the bell. Then here the patient has to stop, and we will measure again his vital signs, and we will ask him about the signs and symptoms. What make him unable to catch the bell? Is it the dyspnea, fatigue, leg fatigue? And we document all this information. The vital signs, we have also to have the Borg scale. So before starting the test or terminating the test, we will ask him again to mark the Borg scale and also the rate of preserved exertion before and after exercise. And we have a recording form which have all the patient information, and also the vital signs before starting the test. And we can just mark here how many level did the patient did, how many round. So when we repeat the test next time, we will compare, like the first time he did 5, second time he did 10, so we can know the level. And there is our equation for calculating the functional capacity of the incremental shuttle walk test, and there is an international cut-off point of the. When I say cut-off point, or when I say like I mean like there is a certain number of level or distance which we can say a patient with coronary artery disease can do average of like 10 level or 12 level, or he can do 60% of the total distance, but we don't have it also for the Saudi population. But there's an international, cut-off point, they call it, for the intermittent shuttle walk test for those patients, and it will be recorded. And if there's any comment, we can write it down, and we can use it as in research, or even if we're using this for the pre-exercise prescription, we will know what level is the patient before even we start the cardiac rehabilitation program or we're starting the exercise program. We know he's in level 3, 4, 5. We know he's in risk stratification, high, low, moderate. We know in METs which level. We know his 6-minute walk test level. So we have all the functional tools measure, in addition to the medical screening that has been done by the physicians, and we have the result. So we have a complete picture of the cardiac patient period to do the exercise prescription or period to start the exercise program. And as I mentioned, this could be done for the outpatient, but for the inpatient, we can use the screening tools done by the physician, and we use our screening, muscle test, range of motion, patient consciousness, our assessment for the patient in inpatient. Now, after knowing all the physician tools of screening and knowing the risk stratifications, meds, our functional capacity of the cardiac patient, I would like to summarize and finish by this exercise prescription and recommendation. Exercise prescribed should be tailored to each individual and according with their physical condition, aerobic and anaerobic fitness, and local muscular condition. Exercise should be suited to each individual in terms of intensity, duration, volume, and in relation to his or her intended level of physical activity of their training goals. What we want to get from this patient. Are we looking for improving endurance level? Are we looking for improving the functional capacity? Are we looking for improving the muscle power, then work in the endurance level? So we have to be knowing what is the goal of our exercise or training program. In addition to that, the activity should be linked to other lifestyle modification to minimize the cardiac risk. So we have to know what is the first underlying diagnosis. As we mentioned before, the prognosis, the risk stratification, all this screening tools, we can use it and to put it here as a direction of tolerating exercise or doing the exercise prescription for those type of patient. Finally, adequate pre and post exercise medical evaluation. If we have all this tests, all this information, we have it before we start with the patient. After finishing the exercise program, we have to redo all this tests. So we have the pre and post state of the patient. So if we want to do a follow-up or we want to adjust our exercise program, all these tools will be available for us. And here I end my talk. Thank you very much for listening to me. I'm sorry if I talk too long, but the topic is really broad, and I tried to bring everything today for you, but I know it's not easy, and I wish I was able to summarize most of the important thing for you.